chronic osteomyelitis and its complications are quite commonly seen in pediatric orthopedic OPD. Chronic osteomyelitis has many problems, like recurrent flares of infection, sinuses draining pus, sequestrae, right from microsequestrum to huge large sequestrum involving the entire diaphysis are seen, cavities, a weak bone leading to pathological fracture, gap. Gap usually results due to removal of large sequestrae or resection of bone, and of course, Brodie's abscess. So the principles of treatment of chronic osteomyelitis are thorough debridement, bold resection of dead tissues, insertion of antibiotic impregnated cement beads or even intramedullary rod. Calcium sulfate beads nowadays are quite useful. Fixation of pathological fracture when it is there. And of course, early coverage of the wound, vacuum assisted closure if needed. So bold resection is very important because the residual infected tissue is the main cause of recurrence of infection. So it is not only the resistant organisms, but inadequate debridement is the main cause. So according to Ciani, he says that debridement is the unchallenged cornerstone of treatment of chronic osteomyelitis. Coming to the pathological fracture now, the bone can fracture in osteomyelitis because it becomes weak due to cavity. Huge cavity can weaken the bone, or sclerosis, or even osteopenia due to infection can weaken the bone and it can fracture. So the principles of treatment are same. We have to debride if there is infection. We can insert antibiotic impregnated beads and we have to fix the pathological fracture. The antibiotic impregnated cement beads need to be removed. So nowadays I prefer calcium sulfate beads which get absorbed completely. So here's a case. This distal end radius fracture was due to this huge cavity here, and there was sequestrum and draining sinus. So I removed this sequestrum, debrided the cavity, and inserted calcium sulfate beads there. So I could close the skin there and there, and I just treated this child in a cast, and this fracture united very well with complete healing of infection. But one cannot be as lucky as that all the time. For example, in this case, this girl came to me after almost 1.5 to 2 years since she had chronic osteomyelitis. She had multiple draining sinuses, lot of sclerosis, many small sequestrae, and because of sclerosis, she broke her femur. So she was also treated conservatively for some time by somebody else, but it didn't work, obviously. I did a thorough debridement. I removed all the infected tissue. I resected the sclerotic bony ends, freshened them, and applied Ilizarov fixator. Allowed her to walk immediately, and look at the union, excellent union with complete healing of infection. This is her 3-year follow-up X-ray, doing very well. This pathological fracture was a segmental fracture. This boy had pan-diphyseal osteomyelitis, and it resulted into segmental fracture in tibia. So this part of the bone was exposed. Somebody drilled holes in his bone, and he was treated again conservatively. He was put in a cast, and he came to me about 1.5 to 2 months, and his fibula united. So I removed the dead necrotic bone and applied Ilizarov fixator, and I distracted through the proximal fracture and did a bone transport. So you can see bone is forming nicely even through this proximal pathological fracture. And the lower fracture was also uniting. So that's the result, complete union of both the pathological fractures and complete cure of infection. And even the soft tissue defect closed on its own completely with the bone transport. Coming to the gaps. Well, removal of large sequestrae or resection of dead bone can result into huge gaps in bones. So treatment options available for gap are, of course, bone transport. Then there is vascular fibular graft, tibia pro fibula, or even non-vascularized free fibular graft. I prefer, of course, bone transport. The other modalities of treatment of treating gap have few problems, like there is always a risk of reinfection, delayed union, or even persistent limb-length discrepancy. Whereas in bone transport, along with bone gap, you can even deal with the soft tissue gap. The soft tissue defects close simultaneously. Limb-length discrepancy can be corrected. Even the deformities, if they are there, can be corrected. So I prefer bone transport. So a few cases. So this girl had these sequestri. So after removal of sequestri and debridement, it resulted into gap. Her fibula was intact, so I did a bone transport. I did a distal corticotomy and did bone transport from distal to proximal side. And you can see good for bone formation. In children, you can get away with a diaphyseal corticotomy. They throw quite good bone and it united very well. She had a little recurvatum deformity, but she was a young child, so it remodeled. Another patient with a huge gap, a large sequestrum was removed from here, and look at the gap, about 8 to 10 centimeters of gap. So even in him, the fibula was intact. So I did a bone transport by doing a proximal corticotomy and did bone transport from proximal to distal. See, very good bone formation at the corticotomy side and a very good union here. This girl had chronic osteomyelitis and somebody removed sequestrum from here in the proximal tibia. She also had destruction of medial and posterior part of growth plate. So she was walking on it. This is quite common in our country. They keep on walking, and then she developed this varus and recurvatum deformity of proximal tibia. There was hypertrophy of fibula. Fibula was overgrown and fibula was also in varus. So I debrided. I actually resected this sclerotic bone here and did acute docking and corrected the deformity gradually. I also ablated the remaining part of growth plate and did a corticotomy distally and bone transport, and that's her union with complete cure of infection. As expected, she came with 4 centimeters of shortening at the age of 16 years. So at this point, I did lengthening with a technique which I have developed and published called as lengthening over slotted plate. So in this technique, I put this slotted plate and one ring above the plate and one ring below the plate. Corticotomy here. I put 3 screws in the proximal holes of the plate and 1 screw in the slot which goes in the distal fragment, and it slides in the slot along with the distal fragment. So as soon as the distraction is over, I put screws in the distal holes and remove the fixator. So this is immediately after removal of fixator. And this is 6 months after removal of fixator. You can see an excellent region rate. Infected non-unions due to chronic osteomyelitis can also be very well treated with Ilizarov, with or without deformity. So this boy had this non-union. He had multiple sequestri, small sequestri, and a draining sinus with intact fibula. So I resected his non-union. I converted the oblique bone ends into transverse. I resected the sclerotic bone and applied Ilizarov fixator. I compressed it for 10 days and then slowly distracted from the same site to gain length. And you can see a good union. This is his 1-year follow-up and this is his 3-year follow-up. This is an infected non-union with severe deformity. So this boy had chronic osteomyelitis. Somebody did debridement and inserted beads, and he also had pathological fracture, which was treated conservatively by somebody else, but it didn't unite. The child continued to walk on it, and he developed this very stiff non-union. So I removed the beads were exposed, I debrided, I removed all the sequestri and applied Ilizarov fixator and corrected the deformity gradually by distraction. So you can see correction of the deformity and even the fracture is uniting. So complete union of the fracture, complete cure of infection. 10 degrees of his recurvatum remained because the bone united before I could correct that. But I'm not worried because I was sure that it would remodel. He was a young boy and his distal femoral growth plate was intact. So as expected, this is his 2 years follow-up, complete remodeling of the recurvatum and full function. So thank you for your kind attention.